Good evening. My name is Shawn McMillan. I'm an orthopedic sports medicine specialist down at Virtua Health outside of Philadelphia in South Jersey. And tonight, myself and Shawn Anthony from Mount Sinai are going to be discussing really the nuances of the BEAR and the stump of the ACL in particular. And does the size of the stump really matter when it comes to the outcomes after the BEAR ACL restoration procedure? It's important to realize that the BEAR, it's not new, it's just different. And it's a different thought philosophy that we have. And it's something to keep in mind that this has been investigated for over 20 years. And we've gone through sort of an iteration of research when it comes to ACLs, where we tried to repair them initially, and then we went to reconstructing them and replacing them. And now we're back to, can we restore them with the BEAR implant? And restoring is the key word there, because we're preserving what's left and putting it back to where it belongs, much like everything else in the body that we treat, like rotator cuffs and MCL injuries. One of the things to consider when you're looking at the BEAR is, how does it work? Well, to do that, we have to understand exactly what the BEAR implant is. And it's a decellularized bovine collagen implant that's able to hold and protect blood in the area of healing where the ACL will reform up against the femoral wall or the tibial plateau. And it blocks out the synovial fluid that we know can slow down the healing process and prevent the clot formation from occurring. It's highly porous, and we know that it resorbs over the course of about 8 weeks, and the procedure can be pretty straightforward once the steps are learned. One of the things to think about, as I mentioned earlier, is the MCL, the rotator cuff, all these different pieces of tissue inside the body can heal. And the way they heal is by scarring and by clot formation. These are extra-articular structures that we're talking about primarily, whereas the ACL is more of an intra-articular structure. And we know that the synovial fluid that builds up around the ACL, particularly after a rupture, when the negative enzymes are released inside the joint, can prevent that scaffold and that clot from forming, basically breaking down the ability of the body to heal the ACL up to the femoral wall or the tibial plateau. The BEAR helps to prevent that. So through clinical research and through clinical studies, we've been able to examine the outcomes of the BEAR. And when we talk about something being new or novel, it's important to realize the BEAR, as I mentioned, has been around for 20 plus years. And there's plenty of research and data that's out there, including level 1 studies, which is different for most of the novel things that we do in orthopedics. Thinking about some of the most key research that we found from the BEAR, we can go ahead and look at things like IKDC scores, re-tear rates, and functional outcomes. So in the BEAR 2 pivotal clinical trial, they assessed IKDC as well as AP laxity at 2 years. And what they found was, in a side-to-side comparison between the BEAR and ACL reconstruction using hamstring tissue, they found that the KT1000 scores were essentially equivocal. And they also found that IKDC scores were actually higher in the BEAR group than the reconstruction group. It stands to reason, without robbing the hamstrings for the reconstruction, the hamstring strength in the BEAR group was also much higher than in the ACL reconstruction group. Looking at the sagittal plane and looking at the ACL in the contralateral knee versus a BEAR restored ACL, you can see that the angle and sort of the kinematics that are maintained in that sagittal plane are really important, and they're the same. So when you think about how good we are with what we do now with our reconstructions, whether it's outside in drilling or anterior medial drilling, we're still never able to recreate that normal angle of the ACL as much as we really think. By being able to restore the ACL to where it belongs, we're able to preserve that function. And in my mind, I think that helps minimize the risk of arthritis by creating and restoring the kinematics that we were born with. And again, as I mentioned, we know the BEAR goes away by 8 weeks, so that ACL tissue is there, attaching the femur to the tibia and allowing some of those proprioceptive fibers to be in contact earlier on, minimizing the risk of micromotion.
Thanks, John, for that great review of the science behind the BEAR implant. One of the most common questions we get from surgeons is, who is the right candidate for the BEAR implant? How can we predict who the right patient is in the office when we're discussing ACL injuries with patients? So we're going to go into that now. So decision-making with the BEAR implant. When we look at the clinical studies, the majority of patients in the clinical studies had mid-substance tears, approximately 57% of patients. And the rest had either about a third had proximal tears, about 10% were repaired using that had a tear type that was in the distal aspect of the ACL. So we are asking the question, with our own patients, does the stump size matter? And how well can the MRI be what's the predictive value of preoperative MRI in the prediction of an ACL tear type? So using a common classification system, type 1 through 5, we looked at type 1, which was a proximal avulsion, type 2, proximal tear, involving the proximal 25%, type 3 is a mid-substance tear, type 4, distal third tear, and type 5, distal avulsion. We went back through all of our BEAR surgeries since 2020, and these were blinded, the MRIs were blinded, and then we looked at our intraoperative records to see what the tear type would be classified at time of arthroscopy. And the two surgeons in the study were myself and Dr. McMillan from Virtua Health. Again, these were all patients, consecutive series from 2020 to 2023. And looking at my results, I had 34 patients that were included in the study. The majorities were ski injuries, and the others either non-sport or soccer is also a common mechanism. Average age was 31 in this cohort. And interestingly, we found that MRI predicted the ACL tear type in only 56% of patients. Most patients on the table on the right, you can see it, most patients on MRI had a type 2 classification, so involving that, not a proximal avulsion, but the upper 25%. Compared to the arthroscopic findings, showed that the majority were actually more of an avulsion type involving, as an avulsion as opposed to the top 25%. In over 90% of these inaccurate predictions, at time of arthroscopy, the tear type was determined to be more proximal and even more amenable to repair than I predicted on the preoperative MRI.
So very similar to Dr. Anthony, we went back and looked at our first 35 patients. Again, very similar demographics between males and females. Our average age was a little bit younger, 24 years of age was on average there. And again, a myriad of mechanisms of injuries, including various sports and competitive sports. And again, looking at these, we were able to sort of isolate, again, in our hands, only 57% of the time were we able to accurately predict the tear size based upon the MRI compared to when we got inside the joint intraoperatively. And again, when we were inaccurate by about 90%, we were off by about one tear size. So it's significant. And that sort of goes to the fact that MRIs are static injuries, and images rather, and the tear oftentimes is sort of balled up or scarred in. And once we get into the knee joint, there's things that we can do to sort of elongate that ACL that the MRI sort of hides from us. So this is a technique that we sort of worked on over time, looking at our patients. And one of the ways that we were able to overcome sort of these ACLs that look sort of shriveled up or scarred in on the MRI is we take time to meticulously tease away the ACL stump. So you saw a spinal needle, and what we did was we made a transpatellar portal, and we've now inserted a grasper through the transpatellar portal while working through a medial portal, and we're lifting up on that ACL stump. So we're elongating it as we pass our sutures with our self-capturing device. And by elongating this and teasing the ACL off of the surrounding soft tissues, teasing it off the PCL, we're able to get a much better, much more robust stump than what the MRI showed us. So I think that's really important to understand that the MRI can be misleading in a negative way sometimes for how much tissue is actually left.
So next, we're going to walk you through some case examples of my own cases and Dr. McMillan's cases. The first case was an example of a proximal avulsion. This was a 28-year-old skier who presented to the office. The MRI had shown a proximal 1/3 tear. She did a course of PT, as all my patients do, for ACL prehab to regain the range of motion. And time to surgery in this case was 60 days. And on the left, you can see the arthroscopic image, which showed this to be more of a proximal avulsion type of injury. There was excellent ACL stump tissue remaining. Now on the right shows what the ACL stump looked like after a modified Bunnell suture pattern had been placed up through the ACL and tensioned on the femoral side over a button. Second example is showing a mid-substance tear. So this was a 33-year-old female skier. Her MRI was obtained approximately 4 weeks after her injury. Also did a course of physical therapy prior to ACL surgery, and her time to surgery was 73 days. And this video shows, what a mid-substance type tear looked like at the time of arthroscopy. These do take a little bit more work to for the suturing of the ACL stump. But using the elongation techniques, as Dr. McMillan showed, you can get excellent control of that ACL stump. So in this example, I used a modified Bunnell type suture with an ultrabraid suture, passing it back and forth up through the stump. And even in this example, where at the initial scope, I put the camera and looked like there wasn't much tissue left to work with, you can see after working with that stump, you can almost get near approximation of the end of the tear back to the femoral wall. This is her at a 3-month visit. What we're finding is our patients have much less pain after surgery. Although initially we go a little slower with the range of motion, they catch up by the 2nd or 3rd week, getting already down to 90 degrees. And then this is her at 3 months. You can see the small size of the incisions as well. This is a 3rd example, also a mid-substance tear, 15-year-old high school soccer player who had a pivoting injury and hurt a pop. Her MRI showed a mid-substance tear. Time to surgery was 40 days in this example. At 9 months post-op, she had full range of motion, negative Lockman and pivot shift in the office. She passed her return to sport tests and was saying that her knee felt normal. And this is an example of her post-op MRI scan, which shows excellent restoration of that ACL tissue or mid-substance tear.
So case 4 is one of my patients, and this is a pretty neat patient. He's a 32-year-old professional fighter. And I think one of the take-home points with this is we learn a lot as we move on. And not only did he have a small stump, as you can be visualized here on his preoperative MRI, but he's someone who basically had determination, but also wasn't going to necessarily follow a slower protocol. And so, based on patients like this, we were able to sort of move forward with some more advanced rehab protocols just from understanding the dynamics around this. But okay, this is a 32-year-old male who has a fight that he states he will not miss in 12 months. So you see his MRI here with a very small tibial stump that's left. 9 months out, here's his ACL. It looks really fantastic in this BEAR sequencing MRI. He was part of our BEAR 3 clinical trial. And one of the things that's important to note is, again, he accelerated his rehab very early on. He was bending the knee much more than even I was comfortable with in the first 2 weeks, 4 weeks, and 6 weeks. But he really focused on really strengthening up the knee and understanding, the right things to do with the knee kinematics in his rehab. Here it is again, a T2 image again showing that normal sagittal and coronal plane, rather, of the MRI and the T2. He ended up getting back to that fight. He ended up fighting at 10.5 months and actually won his title, his first title. He's 4-0 since coming back from his BEAR ACL right now. And really, it's a testament to what you can do with good science and determination, as well as understanding how the body wants to heal itself if given the opportunity. The next case, though, is again pretty interesting here. This is a patient of mine, a collegiate soccer player. You can see the image on the left is her ACL tear. Again, you see a small stump there, maybe 50% left at most if you're lucky there. She went through again the BEAR clinical trial, BEAR 3 clinical trial. These are her 9-month MRIs in the center and on the far right. Again, seeing a good ACL that's intact and healthy. She again passed all of her post-surgical metrics to get back onto the field. And we let her back on the field with an ACL functional brace. And she was having a really good season. Next slide. And unfortunately, when we again went ahead, keep going there, Shawn. This was the day of her surgery. That's what the ACL looked like. Again, we were able to get a nice repair. This is viewing the ACL stump before we put it back up. You can see a nice, robust ACL that was left. And we were able to go ahead and tease that away and see this is more of a mid-substance proximal tear. There's her 9-month ACL post-op, as we showed before. And unfortunately, when she went back to play 18 months out, she took a pretty devastating valgus hit. She had a bucket handle meniscus tear. and obviously had to go into the knee and concerned about the integrity of the ACL. But this is looking at it, and you can see the picture on the left. This is pretty common. When the ACL heals with a BEAR, there's a lot of extra synovium that'll sometimes overgrow in front of that ACL. Don't be scared by it. Don't be intimidated by it. Don't be concerned on the MRI. Understand that ACL is there. Do a good exam in the office. She had a negative Lockman test, a negative pivot shift, but again, the concern was there. What if it retore? So we teased away some of that scar tissue, and you can see that on the left there. And the picture on the right shows this nice, robust, healthy ACL that's there. I removed the previous ACL sutures that were there. And again, really nice, healthy looking ACL. So we felt really good about this, gave her a meniscal repair. I actually saw her back the other day. She's now 5 months removed from the bucket handle meniscus, and we're getting her back onto the field in an advanced protocol now. So it felt really good about the fact that the BEAR was able to take a pretty large valgus load to the knee, withstand a torn meniscus, and still able to do everything she needs to moving on. So this was really one of those moments where I said, geez, this thing's pretty darn strong, and I don't need to worry about this nearly as much as we might be concerned about otherwise. What was neat about this, though, was all along the ACL, we took biopsies when we went back at that 18-month follow-up, and we took it at the at the insertion site. We took it up by the femur, down by the tibia, and what came back to us, and we didn't speak to our pathologist, we just sent all these specimens off, was normal ACL tissue, right? So that was pretty important to me to see, not that this was sort of scar tissue that was in there. This is tissue that looked very similar all along the pathway of the ACL. So again, one of those things that sort of lit off a light bulb that, in fact, the body is healing and regenerating and restoring normal ACL functional tissue, which to me means that there's longevity that's going to be inside that ACL moving forward.
So I think in conclusion, one of the things in conclusion, we can say that BEAR ACL restoration is a paradigm shift in how we treat ACL injuries. Now, in patients in the office, I present it to all my patients when they tear their ACL, that we have ACL repair, ACL restoration, ACL reconstruction. And based on the data that we've looked at our preoperative MRIs, we can tell that the intraoperative assessment of the ACL stump size is often better than what we can predict based on our preoperative MRI. So don't be afraid to offer BEAR implants to your patients when you see their preoperative MRI. We've had excellent clinical success, and that's also been replicated in the published literature. And the ongoing BEAR registry is going to be a fantastic resource to see real-world outcomes and show the continued success out in the real world with surgeons across the country.